Good evening, Australia. Good morning for the others. Thank you for joining us online for this first webinar featuring Tina Mayo. Thank you, Tina, for being with us today. So Tina will be our expert of the day in shockwave therapy today, talking about Swiss DolorClast communication strategies. So first, to introduce myself, so my name is Mary-Christine Collet. I'm responsible for all educational activities around shockwave therapy and with the Swiss DolorClast Academy. So what is the Swiss DolorClast Academy, known commonly as the SDCA? So the SDCA is the training organization offering shockwave training programs worldwide to the experts, to the, let's say, the experts of tomorrow in shockwave therapy. And we have a circle of shockwave experts worldwide to help us spread the message, like Tina for today. So to come back to our webinar, and before starting the webinar with Tina, before she introduces herself, so as you can see on your screen, you have at the bottom of your screen a chat and a Q&A icons. Please feel free to use them to put your questions in these sections, and we'll be able to answer them during the webinar. And so I guess it's for technical points, it's fine now. So Tina, I leave you the floor. Over to you. Thank you for being with us, and let's start the show. So I think you can share your presentation, your slides.
Yep.
Perfect.
Okay, can everybody see that?
So,
Has that come through, MC?
yes, I think everybody, yes.
Everyone can see?
Everybody can see. Yes, everybody can see your slides. Hello,
Great.
Isabella from Melbourne. Hello from Malaysia, Jessica. Hi.
Okay. Well, hello everyone. Again, thank you for joining us this evening. I'm really excited to be here and very honoured to be asked to conduct this presentation to everybody. So I do quite a lot of other, I train other practitioners on how to use this technology here in Australia. So it's great to have an opportunity to share some of the things that we discuss in our courses here with the rest of the world, really. So to start with, I wanted to discuss why I sort of suggested that maybe communication would be a good topic for today's webinar. And that's purely because whenever we have the courses where we teach other practitioners on how to use the equipment, they understand the science, the technology is fantastic, the research is really good for this product. So we don't have a hard time convincing them that the technology is good, but I always find that afterwards, a lot of the emails or the questions I get asked is, you know, we know that technology is good and that it works, but we don't know how to convince our patients that this is a good idea or that shockwave is suitable for their condition. And on the other hand, we also have the people who've bought the machine. So sometimes they're the owners of the clinics and the practices saying, I bought this machine, but my colleagues and my workers, they don't really have the confidence to use it, and they don't know how to explain it to patients well. So basically then I sort of contact them and we get together and we discuss how important communication is. And then we talk about how best to explain to your patients what shockwave is and how it works. So the questions I posed for this was basically, how do I convince a patient that shockwave is effective for their condition? And if your staff aren't using DolorClast as much as they could be, what can you do to help with them having that confidence to go ahead and put it into their practice? Okay, so I've also put in the presentation quite a lot, you'll notice, in quotation marks, and that's basically script. So they're the sorts of things I would say to a patient to help explain it. So I've put them in word for word because I want you to have them as a reference, and you will be getting, you can have access to these slides after the presentation. So you don't need to take notes, you can just listen. So why communication before science? So for me, obviously science is very important. But we know that if you can't, if your patient doesn't trust you, if you don't have good rapport and they don't believe in you as a practitioner, it doesn't matter how good the technology is or whatever you've got to offer, that comes first. So we need to have this connection with the patient so that they allow us to then recommend whatever treatment we think is appropriate. And that's not just shockwave, that's just treatment in general. So we have to really work on building that connection with our patients, and that comes down to how we sell ourselves as a practitioner and the way we present ourselves. And then secondly, the science, the evidence, proving our techniques are good, our treatment is good, our technology is effective. That's very easy because we've got proof of all that. We need to, but we don't have proof that we're a good person. Sometimes if we're recommended, then automatically there's a little bit of rapport there because someone else has recommended you. But I think, you know, in the treatment, when you first meet a patient, this is when that happens immediately in the first few seconds that you come into contact with them. So what we should know as clinicians. So I think it doesn't matter what background what practice you are. So if you're a chiropractor, a physiotherapist, an osteopath, a podiatrist, it doesn't really matter. I think what we need to know as clinicians, if we're going to use this technology, are basic things like what a shockwave is and how the DolorClast technology works. So we're going to discuss this a little bit tonight. We need to be able to explain the indications that DolorClast can be used for. So understand the research that's been done, the things that have been proven, the studies, and that way we can very confidently explain this to patients. What the patient will experience. So I think it's crucial that if you're going to administer this treatment on somebody, that you've had a go at having it done on you. So you understand exactly what it feels like, what the pain's like, why they might jump, the fear that might go with just the term shockwave. Some people say, is that like electrocution? Like they don't even know that, you know, for them in their head, when you say a shockwave, they have all sorts of ideas that might pop into their head. So I think if you've been through it, you can say, I've even had it, you know, done on me, and that also makes them feel a little bit more reassured that they're going to be fine. Believe in the treatment. So again, if you've had an experience that's positive with the shockwave, then automatically your belief grows that the technology is good, the treatment works, you've had good results. So I think if you don't believe in it, it's very hard for them to believe in you, trying to tell them that this is a good idea. So if you have trouble believing in it because you're not sure about the research, or you're not sure about the technology, or, you know, people tell you different things, I think try get a really good understanding. Connect with someone that might be able to help you believe in the treatment a little bit more. Speak to someone who's had more experience, and perhaps that will help you believe in the treatment, and therefore that comes across when you're trying to explain it to patients. Understand that it is efficient and safe. So again, we've got lots of research to tell us that we can't really do a lot of harm to someone as long as we avoid, obviously, contraindications, but it is very efficient and it is very safe. So we need to understand that, because that also gives us confidence in the technology. That you've read and understood the research that's been done. Again, I can't stress that enough. If you feel like you're not well versed, there's lots of it available on the database that's, you know, for free. You don't have to pay for that. So everyone should have access to this information. And if you need any links or any particular conditions, we're happy to share that with you. Be comfortable with the idea that you need to sell the concept of shockwave. And some practitioners don't want to sound like they're selling anything, or like a salesperson, or, you know, they have this idea that that's not what you do as a health practitioner. But unfortunately, we sell the idea for people, like the idea of being proactive, the idea of being healthy, the idea of doing, you know, be able to engage with patients. That's all, you know, to be able to do that is you're basically selling yourself, and you're almost performing in front of a patient every time you do that. So you need to bring 100% to every treatment to be able to convince them it's a good idea. So that selling concept is something I think we need to sort of get our head around, and it's not a bad thing. It's just the way they perceive what we're saying. So, and I think that's no different if you were doing needling or if you were doing other treatment. You need to sell the idea to them that this is going to be good for their condition. The best communicators achieve the best results, not the best clinicians. So I did a course a few weeks ago with my team, and one of the quotes that was, or one of the things they told us in that course was that basically you could be a 10 out of 10 clinician, like your clinical knowledge could be unbelievable. But if you're a 5 out of 10 communicator, then people will remember you as a 5 out of 10. So it doesn't matter how smart you are, if you're not a good communicator, all they remember, unfortunately, is the way you communicate. So that really stuck with me, and I thought it's so true. Like sometimes, you know, the smartest people are not the best communicators, and that's where they lose patients, unfortunately. And it's nothing, sometimes it's something that they need to work on. So academically, they're great, but they might need to try and develop some of those communication skills. And there's still skills that we probably should spend a bit more time at university working on. Okay, so I'm going to quickly go over what is a shockwave. So we know the technological terms for shockwave. So it's a, you know, obviously in physics, they say it's a type of propagating wave. It moves faster than the local speed of sound in the medium. It's characterized by an abrupt change in pressure, temperature, and the density of the medium and the energy it carries through, which dissipates relatively quickly with distance. So that's its, you know, definition. I generally say to patients, if they say, what's a shockwave? I say, it's just a wave that moves faster than the speed of sound. It happens so quickly that you get a change in the pressure in the tissues. The temperature will change, so we get a lot of heat. The fluid surrounding it is also impacted. So even though the applicator we might be using is only a 15 millimeter, we're actually impacting the tissue much further than that. So I explain it like it sprays out the shockwave. So, you know, we could cover an area of like possibly 4 centimeters instead of the 15 millimeter, okay? And then when I sort of show them the device, and then I explain to them that, you know, what the device is. So then I say, so this is the shockwave device. I say inside it, it's attached to a compressor, and the compressed air that it basically sends air up through the tube into the device. There's a bullet inside a bullet or a projectile inside the handpiece. And every time that projectile taps on the end of the applicator, we have a shockwave emitted. So I try and use as simple terms as possible. I also tell them it hits the applicator really fast. It's like 90 kilometers an hour. So, and the shockwave that's emitted, that's transferred into the tissues, can happen 20 times a second. So if you think about that, there's nothing I can do with my hands that can replicate the same as what the shockwave is doing, the same treatment. So I can't put that much pressure in the tissues. I can't create that much blood flow. I can't do anything physically with my hands that the shockwave can do. So that's the best part about it. So as soon as I say, it's basically, I'm not using it because I'm being lazy. I'm using it because it creates a physiological change that I can't create with anything else. Okay, so this is the other really important thing that I will always discuss with the patient, and that's the energy signature of the DolorClast. So this is how we explain how effective it is, and this is why we know it's effective. So not all shock waves create a therapeutic effect. So just because something says it creates a shock wave doesn't mean it's going to have a beneficial change to their injury or to their pain. So we see a sudden rise in pressure, and that's called the compression phase. This creates a positive energy density. So we can see that in the graph there. So I think I can bring my mouse across here. So you can see this really high pressure, and that has to happen so quickly. And this happens with the DolorClast, that as a result, it causes some stress in the tissues. So when we say stress, we also compress the actual head of the DolorClast into the tissues. So we're making sure that that shockwave goes into the person and not back into us as the practitioner. That's really important. And that's sometimes an error I see with some new practitioners. I see them sort of not actually compressing and maximizing the benefit of that stress in the tissue. So that's really important. Then we see a sudden drop in pressure. This is known as the tensile phase. So when this comes down, and this is where this negative pressure here, that's when we get the formation of little cavitation bubbles. So the greater this energy flux density, which is this big high peak here, the greater the therapeutic effect, because the more cavitation happens here. So what I'm saying is, if you've got a shockwave unit that produces a shockwave, but the pressure is not significant enough to create this cavitation, this is where the benefit happens, that negative pressure. And if we look at these images here, so we can see on the right here, these tiny little bubbles. So that's the initial shock that happens. And these are secondary shocks that you see. So can you see the rippling effect that spreads through the tissues? That's really important. And that's why I'm saying beyond the tip of the applicator here that we see in this picture, we see the effects go much further than that and much wider. So it's like a ripple effect that you can see. So if a patient comes in and I try and explain to them that I think shockwave's a good idea, and they say, oh no, I've already had it and it wasn't good, didn't work. And so I always ask them, was it done with the same device? And I'll show them the machine. And if they say, oh no, it was a bit different. So then I explain cavitation to them, because it's really important they understand that perhaps that's why they didn't actually get a good result. So I say, this is what I've written here. So the energy flux density that we talked about, explain that to them, and explain that if it doesn't happen quick enough, just because it makes a noise and it sounds like a shockwave, doesn't mean we've got cavitation happening. So I hope that's clear. So when we talk about pain, so obviously, sorry?
Tina, we have a question from one of our participants, a question from Heidi. Should we offer earplugs to patients? Can we use as a one-off trigger point during a remedial massage?
Yeah, so with the earplugs, because you want to ask the patient how they're feeling while they're having the shockwave done. So I constantly, I use a pain scale and I say, out of 10, how is the pain? So I need them to still be able to hear me. That would be my only issue with the earplugs.
Okay. Thank you.
Yeah, that's okay. So if we talk about pain, this is a good analogy, the red chili peppers effect. And, for those of you who might have done the training have been through this before. So we know that when our C nerve fibers release substance P in the tissue, and that's, obviously, when we have pain and when we have inflammation. And that's sometimes why they will experience some discomfort when they're having the shockwave treatment done. But we know that as we activate those C fibers with the shockwave, the more we deliver those shocks, the more inhibited that substance P becomes. And that's what reduces the pain and creates that numbing effect. So I explain this as a local analgesic effect to patients. They will often say, oh, that feels similar to when I had a cortisone injection. That also creates a numbness in the area. How does it work to reduce pain? So I simply say, when we have an injury, we have these C nerve fibers, they report pain to our brain, and they release the substance P in the tissue and the spinal cord. And the shockwave actually gets rid of that substance P, so we don't have the pain. It also reduces inflammation. So I think they're really important things to highlight. Who doesn't want to reduce inflammation when they've got pain? Almost everyone. So I think, and obviously, telling them that it works to inhibit the actual chemicals that cause pain, and we know the effects are long lasting. It's not just an immediate change, which is really important. I like to use a pain scale, as I just said, to determine when substance P is being depleted. So I say to them, as we deliver the shock waves, I will ask you to let me know when you feel the pain reducing. Your feedback will dictate the course of the treatment. So when I palpate initially, I'll say, how's the pain out of 10? So if they say, oh, that's about an 8, I'm like, okay. Then when I put the shock wave on, they might say, oh, that's a 10. So I've actually increased the pain by applying the shock wave. So then I'll try and talk them through just keeping them calm, keeping them relaxed, keep them breathing and reassure them, and keep telling them, let me know when you feel it starting to ease. As soon as they tell me it's starting to ease, in my head, I'm already thinking substance P is going. I'm starting to be effective. This is working. The patient's responding. This is all really good. So then I make sure I tell them that that's the response we'd expect. So they're not sitting there wondering, is she just hammering me for 3 minutes here and not telling me anything? So constantly communicating is very important. Just constant reassurance. This is normal. This is what you should be feeling. That's really crucial at this point. The mechanisms of action. So understanding what mechanisms the DolorClast has on different tissues is also really important. So there's so much literature that you can read about. But if I briefly cover its effect on the nerves, so we get a hyperstimulation of the nerves, we get the removal of substance P like we just talked about, and we block that inflammation. So that's the biggest effect on the nervous system. If we talk about tendons, the biggest change is we get an improvement in tendons gliding thanks to lubricin. And this is probably one of the best effects I feel as a practitioner that this machine has on a tendon, especially a chronic tendon, which has no lubrication around it, has real trouble gliding in and out of the sheath that surrounds it. So we know that shockwave can actually cause the sheath around the tendon to secrete more lubricin, which is amazing. And I think that's probably the best thing you could introduce to a tendon that's feeling quite compromised. When we talk about bones and we talk about and cartilage, for example. So if we've got less cartilage, degradation of cartilage, osteoarthritis, lubricin is also secreted by the capsule of the joint. So when we've got a joint that doesn't glide very well, if we can improve the lubricin being secreted, again, you're going to improve. The joint actually feels like you've put oil in that joint. And so I love that effect. So osteoarthritis is one of my favorite things to treat with the shockwave. And I use the power handle for the osteoarthritis conditions, because we know that has more impact. It also, if we talk about bones, we talk about proliferation and differentiation of osteoblasts and new bone remodeling. So stress fractures, things like that. New bone formation can be really useful and proven to work. And with muscles, so as I said before, the removal of substance P from trigger points, improving circulation and relaxing muscles. So you can actually feel a positive change in the tissue after you've shockwaved it. You can actually feel it softens. You can feel trigger points release. And even a patient, even if they can self-palpate, I always say to them, feel that, can you feel that area? Feel how ropey that feels, how hard that feels. And then I make them feel it afterwards. So whether I'm treating a trigger point in a hand or, in a forearm, it doesn't matter. Get them to palpate and feel the difference.
Tina?
So sorry.
Sorry to interrupt you. We have a few questions concerning the relation to patients. We have a question saying, is there any relation to patient experiencing headache after having shockwave? Had a patient treated for gluteal tendinopathy, great result with shockwave, but every time had a headache after treatment.
Really? Okay. Unless it was, anxiety related or stress related possibly, but I can't say that I've had someone that make that connection between shockwave and a headache. But I mean, I suppose you are increasing a lot of blood flow to the tissue, so you could get a systemic response. So I don't think it's unreasonable, but I personally haven't had that experience.
Thank you. We have another question from Greg Robinson. So to achieve the ripple effect, do you want to keep the head on the same painful area, or can keep moving the head in small circles around and over the area and still achieve the benefit? Yeah,
so that's a great question. So initially when I first was taught, and I was told to keep the head still, but then when I attended the second lot of training, I was told to keep the head moving. And I feel like it makes more sense. So if you keep the head moving, you actually impact more tissue surrounding the area. So sometimes if a location is very tender, I would say work around it and work your way into the most tender spot if that helps the patient. So moving the head is completely fine and recommended.
Okay, thank you. Thank you. We have a last question saying, so when you ask a patient if they have used the same machine as you have and they say no, does that mean that no other shockwave unit is actually producing shockwaves? if they ask us, this is what do we reply?
Yeah, so I would just say that, you know, there is research to support this sort of shockwave that comes out of different units. So I would recommend that, you know, if they know the brand, they can look it up themselves if you like, or you can share that research with them that shows that this machine is actually effective. So I'm not out to bag all the other machines, but all I'm saying is making sure that if you're going to put them through the pain, make sure it's actually going to be an effective treatment. So, and I'll go on to sort of explain that a little bit more, but I think it's not that I'm saying no other machine is you know, as good, but this machine is the one we know does produce an effective shockwave. So that's all I would say, and we've got research to support that. Does that answer the question?
Yes. Thank you. We have a couple of other questions that maybe I'll let you continue the presentation because it's linked to indications.
Okay, sure. So when we're talking about indications, so these list of indications we have here on the screen, we have evidence to support all of these, and that, you know, obviously the DolorClast is effective for. So there are some things on here that, you know, potentially you might treat that are not on the list and still getting great results with, because when you understand the science and the technology, it makes sense that if you want to increase blood flow to an area, if you want to create a local analgesic response, if you want to do any of these things, then as long as you're safe, you can still be quite effective for conditions that might not necessarily have research to currently support it. So if we talk about tendinopathies, calcifying tendinitis of the shoulder, subacromial pain syndrome, primary long bicipital tenosynovitis, tennis elbow, golfer's elbow, greater trochanteric pain syndrome, patella tendinopathy, Achilles, plantar fasciopathy, all these lists, so you can read through that list yourself. All these things, so we've got a combination of things that affect tendons, we've got a combination of things that are affecting, you know, so acute and chronic. We've got capsulitis, so the capsule around a shoulder. We've got trigger points, we've got muscular conditions, we've got general chronic lumbar pain, we've got stress fractures. So think about all the tissues that you're impacting, heel spurs, connective tissue disorders, spasticities, all these sorts of things. So you can impact quite a lot of different tissues. So the physiological changes are not just superficial. You've got to think about for you to be able to help, for this machine to be able to work with all these conditions, it's obviously got to go to quite a deep level. Some of these indications like calcifications are quite deep. So again, it's impacting tissue that you cannot physically reach with your hands. So keeping that in mind, that, you know, this is not a magic wand, but it's very useful and very effective for things that are deeper than what we can reach with the sort of practice we normally do. Okay, the other thing I do say to them is that if you're currently using the DolorClast, you should be listed as part of the academy, so people can find you all over the world. So if someone happens to be traveling and they're on their side of the world, they can look up who's someone that's a Swiss part of the Swiss DolorClast Academy that can give me some shockwave. So if you're not on the list, you should be. So I do say to them, I'm part of the international SDSA. As this treatment using the DolorClast is recognised worldwide. So sometimes people say, oh, I haven't heard of it. And you're like, oh, okay, you can tell them that. You can tell them it's used by 5,000 certified practitioners in more than 30 countries. So it's internationally recognised, which is really important. Most of the reliable research published on shockwave has been done using this same machine. So that really comforts me, and that's why I have no problem recommending it. And I'm happy to use it with people. So if I didn't have the research to prove its therapeutic effect, I would not use it. So this is something I would often say as well, because I wouldn't use something that didn't have evidence to support it. So, and I would only use the top of the range in shockwave equipment on my patients. So I want them to understand that, yes, it's expensive, and yes, there are cheaper versions around, but I feel like this is it. I don't think, you know, your patients are something you compromise on as a practitioner. This database is also a great reference if you haven't seen it before. This is the Pedro database available. And this lists the shockwave articles, some of the ones that we've spoken about, the conditions we've spoken about. So you can look at the indication and then you can find the studies on that indication. So if you're really interested, or say you see a lot of people that suffer with plantar fasciitis, then you'd go to this section, have a look at the articles, and you'll notice all the red ones have been done using the DolorClast machine. And that's really, that also is really comforting, because you go, okay, well, look how much research there is on a database that's quite reliable. And therefore, if you need to send anyone to read the research, you've got a list of that available.
Ina,
okay, so yep.
Sorry to interrupt again. We have a few questions concerning
That's
a couple of conditions. We have a question from Fanny asking if we can apply shockwave therapy around the backbone near the lungs.
Yes, so one of the lungs are a contraindication. So air-filled spaces, we don't shockwave over. Any particular part of the backbone, or just in general? Because the lumbar spine, like lower lumbars are fine, like that would be okay.
Yeah. Yeah. So we have another question from a participant asking if what's the difference between focused and radial shockwave? Is one better than the other for treating these conditions?
So there are two different types of shock waves. So the machine we're talking about tonight, and the one I use, does radial shock waves. So I actually don't have much experience with the focused shockwave unit. So I understand it is used for deep indications, but sorry, I can't give you more information about that.
Okay, thank you.
I think for most musculoskeletal conditions, the radial shockwave is what we, so as an osteopath, that's they're the sort of conditions that we treat.
Okay. Thank you. And we have another question from Vanilla asking if we can treat patients suffering from osteoporosis with shockwave therapy.
Yeah, so again, it probably depends on the degree of osteoporosis that they have. So if it was mild, then they would be fine. But if it was severe, you'd probably run it past their doctor. I would check with their doctor or their specialist beforehand.
You mean
so
come
if they were
with an ultrasound? You mean come with an ultrasound? And...
You could use an ultrasound, but I'd just be concerned about putting a shockwave through a frail bone. So I'd need to know the extent of the osteoporosis.
Thank you. I'll let you continue the presentation.
Thank you. Okay, so this exercise was also something that we participated in as a team a few weeks ago in a course, and I thought it was a really good, valuable tool. So I'd like everyone to try, we're going to take a video of ourselves. So I'd like you to take your phone out, and you're going to take a video of yourself as a practitioner speaking to a patient, because this is what patients see. So the way you explain yourself, the way you present yourself, I want you to test, almost do a practice of how you would explain. So if I'm your patient, I come in and I have plantar fasciitis, and you suggest shockwave treatment, and I, as the patient, ask you, what is shockwave and how does it work? So using your phone, I'd like you to video record yourself answering those two questions as you would, as though you've got the patient in front of you. And so try and see most of your body, and just, if you can set your phone up. So I'll give you a minute or so to do that, because you should be able to have a little spiel ready. That's, because these are common questions you're going to get in clinic. So I'd like you to do that, and then we'll continue after you've done that. So I'll give you a minute. Okay, so hopefully you've all managed to do that. Now I'd like you to watch the video with your sound on. And what do you notice about yourself? So have a look, rewatch the video you just took, because this is what patients see. And maybe in the chat, you could just write in what you notice about yourself. Good, bad, or otherwise. Are you getting any responses there, MC?
No answer yet. Somebody, well, Neil was telling that he's watching his phone and stumbling on words. Yeah, people are saying they sound terrible. Some of them are reassuring and professional.
Yep.
I guess they're, let's say, they feel confident about the treatment when talking to the patients.
Great. Okay, so now take away the sound and watch your body language. What do you notice? So mute the volume on your video, watch it again. What's your body doing? How do you stand? What are your hands doing? And again, in the chat, if you could just write in there what you're noticing about yourself.
We have a remark from Fanny saying that he does not quite understand himself. The body language is funny. No, actually, Igor, the video is not supposed to be transmitted. You just communicate to us what is your body language.
You don't need to send it to us. This is purely for yourself.
Exactly. So we have Alison saying that hands are waving around for a bit, but she's standing solid. Yeah.
Okay, good.
Yeah.
Excellent. Okay, now just listen to your voice and don't watch yourself. So what do you hear when you're just listening? So just sound, don't put your phone, move your phone away and don't look at it and just listen.
So what do you hear?
Yes, what do you hear?
Anyone has any comments?
Any comments about what you're hearing?
About your great voice? When I did the exercise, I sounded a bit confused. I'm not self-confident enough.
Okay, yep. It's very common.
So we have a comment from Alison saying that she sounds like she's experienced on the subject. So
okay, very good.
I guess she practiced a lot.
Excellent. So great. The video doesn't lie. So what we're seeing, this is what your patients see and hear. So if you don't like how you sound, or you think you don't look confident, or you know what you're explaining is a bit mumbly, or you say a lot, or you pause a lot, or you speak too fast, like all these things, I want you to just take notice of what your patients actually see. So I think that's a really good way to assess yourself. And you need to feel comfortable explaining what is shockwave, how does it work? The two most important questions. Hopefully after today, you feel like when you next treat a patient and you're going to use shockwave, you're a lot more comfortable. So skills of a good clinician, when we talk about communication skills, so practice using simple language. We've talked about this already. So we don't need medical terminology. They don't understand any of that. And so sometimes they just look at you like, what was that? Like they're so confused by what you're saying. So practice using simple language. Even talking to your colleagues, it's easy to just use technical language, but then you need to switch when it's a patient. You need everyday terms to explain the same things. Your body language. So are you fidgeting? Are you slumping? Like what's your posture like? So even just the way you stand instills confidence in what you're saying. So that's why it's good to just look at what your body does as opposed to listening and looking at your body. So it's good to separate the two. Eye contact, again, that's how we connect with people, and we should be able to, if we have trouble making eye contact, we need to practice it. We can practice all these things. Practice being compassionate. So understanding, put yourself in their position. They might be frustrated, they're in pain, they can't work, they can't play sport for whatever reason. Try and put yourself in their shoes, because that will automatically make you more compassionate. Show empathy. Show that you care. You're not just there to just take their money. You really do care that they get better, and then that they tell other people about how good you were as a practitioner. Your gestures. So what are your hands doing? Are your hands just sitting down by your side awkwardly? Or do you naturally use your hands to explain things and use gestures? My background's Italian, so this comes very natural to me, gestures. But not everybody finds that comfortable. So sometimes it's a good way of being more expressive, of really highlighting things that are important. Your energy, so how positive you are, you know, even if you're tired, even if you've had a terrible sleep, if your kids kept you up at night, for whatever reason, you might feel a bit flat, but you've got to turn on the energy in front of a patient. Think of it like you can't afford to bring that negative energy or that tiredness or whatever into the clinic room. Be confident. So again, this is super important. And sometimes the only way we get more confident is if we practice things. So we're confident when we speak, we're speaking clearly, we're not mumbling. We don't say a lot while we're trying to think of what we're going to say. So speaking clearly, really, really important. The rate of speech. Don't speak too fast because they can't understand you. Your rate of speech, just keep it at a very normal pace, but videoing yourself, you might be able to say, gee, I speak fast. I didn't realize I talk that fast. So that might highlight, or if you sound boring, or if you're talking on a monotone and you always sound the same, like a robot, that's no good either. So your volume often dictates your enthusiasm. So if you're really excited about something, or you're really, confident that this treatment's going to help this patient who's perhaps had a chronic plantar fasciitis for 2 years, then all of a sudden you can be enthusiastic because you can go, oh, I've got just the thing for you. We're going to try this treatment today. And automatically they get excited and hopeful because you've got something and you sound like really positive about this treatment that they might not have had experience with before. Authenticity. So be authentic. People know if you're being fake. So be yourself, but, be honest with patients as well. I think they really appreciate that. Also good communication skills. So I think good clinicians as well, they're prepared for various outcomes. So you're never shocked when someone tells you something. You always act ready, even if you're not. So you need to be prepared. So if they say this, was really good or this was really bad, and this might be more so when they come back after the first treatment. So this might be the second visit. So you don't know what's going to happen. Did they respond well or did they not? So if you're ready for either way, then you sound better than standing there like stunned and not, and awkward and you don't know what to say to them. So if you're prepared, you always come across better. Be a good listener. So try, again, this is probably should be top of the list really for a communication skill. So you need to pick up on what sort of things are bothering them and the injury that they've got, what is it not allowing them to do? So that comes down to how good you are at listening to what they're telling you. Rapport with patients is key. So if we build good rapport, so if we're a good communicator, this is easy. If we're not a good communicator, this is hard. So this is the best way to maximize compliance from your patients. So when we've got patients who perhaps have been around to lots of different practitioners, trying different clinics, and they haven't found someone they've connected with, they haven't found that rapport with someone. So this is really important. And again, this is established from the very beginning. Connect with them first. So it doesn't matter on what you know, what it is. So it could be anything that you use to make that connection. It could be something as simple as, you know, it could be someone who plays football or soccer that comes in. So for the people overseas, it's soccer. Here we call it football. So we're, you know, getting them to understand that, you know, they might come in with a hamstring injury and we say, oh, so, you know, this is a problem that we see in all footballers. So automatically they might play a very amateur league of football, and, you know, not very, it doesn't matter. They just want to feel that they belong to a group of people. So all of a sudden you're saying this is a common injury amongst footballers. You automatically, you know, made them feel important, made them feel like a footballer. That's really, that little connection you make that automatically gives them a little bit of a lift is just something you've done to sort of bring them in and get them to, you know, believe in you. And you go, oh, great, she's seen other footballers with hamstring injuries, and automatically we've like clicked. So earn their trust, and then you can influence their decisions on trying shockwave as a treatment. So if they don't trust you, then it's very hard to influence any decision. So if I'm going to try and use a treatment modality that's very painful on you, but I know is going to be very effective for your condition, I need you to trust me first. And so automatically, if someone's referred a patient to you, they actually already trust, there's already a little bit of trust there, because they've traveled from who knows where to come and find you because someone else said you're really good. So if you've already got a word of mouth referral, you're already one step closer. But if you've got someone who just found you on the internet, just walked in off the street, who doesn't know you at all, no recommendation, no word of mouth, you've got to work hard to get their trust straight up, okay? Especially if you're thinking, I need to influence their decision. I need them to understand that I think shockwave is the best treatment for them right now. And we get better patient outcomes if we've got good rapport. So I did this sort of, I tried to sort of lay out a bit of a plan. So how do we introduce the idea of shockwave? So it's always around pain. Like, most people will come to you because they're in pain. So at the moment, our first priority is getting your pain under control. So that's number one. So what are we going to do about that? So I think for your condition, shockwave's going to be the right tool for this tendon problem that's presented today. So let's say we've got an Achilles tendon. So I'll always say, if we've got equipment that can actually, you know, we can get a local analgesic response in that tissue where you've got the pain, that's going to be great. That's going to be a great change and a great goal for today's treatment. So have you heard of shockwave treatment? And they will say yes or no. So if they say no, then you've got a few things that you could potentially bring up. You can say things like, well, I think it would be a great idea for your condition because, and then maybe you'll say the research shows us. I have treated this condition before with shockwave. It was really effective. It only takes a few minutes, and the research tells us that in 3 to 4 sessions, there's an 80% improvement. It's now known to be as effective and less harmful than cortisone. Very powerful statements. So be very confident with your delivery of those. And you can use any of these or a version of these. And what are these things doing? You're basically, so if you look at the next column, we've got, you're instilling your expertise. You're an expert in your field. And as you do that, their belief in you grows. If you're telling them, I saw someone else with the same problem and it was really effective, you're telling them a story. Stories are powerful. Stories take up space in people's brains and they stick. So they will remember. Building a connection by doing that, by telling them a story, again, we're connecting. It only takes 3 or 4 minutes. So this is very positive. You're giving them hope. Empathy. So if, we know that it's less harmful than cortisone, we care about them. We care that cortisone is damaging and we don't want to put them through that. So that comes down to being compassionate. So empathy and compassion, they're very strong. But again, I don't think we're taught at university how important these sorts of skills are. So if someone says, yes, they have heard of shockwave, I tried it and it didn't work. You can say things like, do you know what type of shockwave machine it was? Or this is the only unit that has research to support it for your condition, potentially. There are several cheaper versions on the market that don't create a strong enough shockwave, therefore they aren't effective. This is the top of the range as far as shockwave machines go. You might say things like, "What would you like me to send you the latest research using this unit for your injury?" So building trust, valuing their time and money, being honest, all really important things to build rapport with your patient. And sometimes I often offer research to people. Would you like me to send you the research? So I'd say if I said it 100 times, I've probably sent it out twice. So not many people actually want it, but the fact that I'm offering it shows that I'm not making it up and I've got proof. So they're both really powerful things as a practitioner. So if they ask me, do you think it will help? Does it actually work? I usually say yes, because unless there's some contraindications, I can say to them, there are several studies which show it to be effective for your condition. And then I discuss cavitation, its therapeutic effect. This is very empowering and you're educating. All these things, again, are helping them believe in you as a practitioner. So you think about your words are powerful. And this is just a very general version, but you know, you could write one of these out for almost every condition that that would walk into your clinic. A treatment plan. So you have to have a treatment plan for shockwave, just like you should for any condition that you're going to treat, whether you're going to use shockwave or not. You should have a plan. So a good, a goal without a plan is just a wish. I think that's a really good quote, because some people feel like we don't necessarily, we'll just see how it goes and we won't have a plan, and it's a bit wishy-washy and it's not very professional, I don't think. And hard to get patients to be compliant if you don't really have a good plan. They think, is she really, thinking along, about, beyond today's treatment, or is she just thinking about right here and now? So you want them to understand and think that you care about them enough that you're thinking, how am I going to get this person better? What's the plan? So establish short and long-term goals. Write them down. Really important. Don't just say them. I think once people have something on paper, it's much more serious. Research tells us 3 or 4 shockwave sessions for the majority of indications. So keep that in mind that, potentially some people respond in 1 treatment, amazing, not often. Some people in 2 are great. They're almost back to normal. But some people need 3, 4, some people need 8 or 10. So I tell them 3 or 4, then we always reassess. Convince them during the first consult, build a relationship. So you need to get them to understand that they're going to potentially need more than 1 treatment, but you need to say this the very first time you see them. You don't wait and then go, oh, next time I see you, oh, we're going to do it again. And they have no idea that they weren't even expecting a second treatment. So when you have the first consult, explain to them that generally we need 3 or 4 sessions for the majority of our indications. Be realistic and honest. So you can tell them that, we'll know in the very first treatment whether or not this treatment's appropriate for you. So when I say that to people, I explain to them that there's a small percentage of the population that don't respond to shockwave, and we're not sure why, but the majority of people do. But if we don't get a change in that first treatment at all, so if your pain is 10 out of 10, and I shockwave you and I go through the whole protocol and it's still a 10 out of 10, I probably wouldn't repeat that procedure again on you. I think that maybe my diagnosis, I've missed something with that, or it's just not appropriate treatment for you. So I'm realistic and I'm honest with people all the time, and they appreciate that. So you need to answer a patient's questions about their condition. Make sure you leave time to answer people's questions, okay? They really value that. So this is an example. The condition normally takes 8 weeks to improve. We have data that shows us healing time can be halved by half using the DolorClast. So I'm going to write down a treatment plan for the next 4 weeks because it's really important we get this right. Then we'll reassess. So you might say, well, you have tennis elbow. We're going to, it doesn't matter what the condition is. So we know that if I was going to treat someone in clinic with tennis elbow without shockwave, and it's chronic, potentially 8 to 10 weeks is pretty normal. So if I can tell them that I've got part of my treatment plan is to use shockwave to shorten the treatment, that's already a big plus. Who doesn't want to get better quicker, especially if I've had a chronic problem for, who knows, 2 years? I'm just so over it. Whatever you can do, everyone wants a quick fix. It's the world we live in now. People are looking for what's the next thing? What can I have that, you know, is going to be better and quicker and heal me sooner? So that's why so many people turn to cortisone, because they're looking for a quick fix, but we know it's not great. So if we use tennis elbow as an example, this might be my plan. I'm going to measure your grip strength. So I'm going to use a gripometer and I'm going to see with your painful elbow, how strong are you versus your non-symptomatic arm, and compare the two. So let's say there's a difference of 15 kilos in the grip you can generate. Then I'm going to shockwave the tendon to reduce the pain, so the lateral epicondyle there. And then I'm going to support it. I'll use tape to unload the tendon. So after I've shockwaved, I always support. So I always do something to reinforce what the shockwave has done. So tape will take pressure off. So make sure when you go home, you rest that tendon that we've shockwaved, maximize the benefit, maximize the blood flow, remind you to rest it because it might be feeling really good. Some people get a bit excited. So remind you to not overuse that tendon. And then I will also retest your grip strength. I will make sure that we do a pre and a post. Objective data is super powerful. So then we retest and I might say, gee, look, you've gained an extra 5 kilos. So in one session today, that's great. Look at the difference compared to what you had before. You can now generate another 5 kilos of grip through that forearm. And then I'll give them exercises to improve their motor control, the way they use their arms. So overall, we've got, you know, a pre and a post test. We've done the shockwave, we've supported it, and we've given them things to take home. This is all part of the treatment plan. So the treatment plan isn't just shockwave once a week for the next 4 weeks. The shockwave fits into your normal treatment plan. So how you're going to get this person better to the end. So if we reassess in 4 weeks' time, I go over everything. I might still have shockwave due once a week for the next 4 weeks, but then at the end of that 4 weeks, we might not need shockwave anymore. But that was part of the plan. And then reassess in a week, usually. So what is shockwave in simple terms? If we've got a tendon problem, I say things like this. It's an effective treatment that can be used instead of cortisone injections, as we now understand the harmful effects of cortisone. And then I often throw this in. Did you know even a single cortisone injection into the plantar fascia tendon can increase your chances of rupturing that tendon up to 12 times? Like, that's crazy. Who wants a cortisone injection? Like, no one after that. If we're talking about osteoarthritis or a deep indication like a supraspinatus that's calcified, I say things like the DolorClast technology is able to reach a depth of 5 to 7 centimeters, depending on which device I'm using. And I can't actually impact any tissue that deep with my hands alone, especially in a joint space. So especially if I'm talking about a knee or an ankle or a foot or a hip. So any deep, big, strong joints that might be osteoarthritic, particularly weight-bearing joints, I often tell them that. So, and again, the results are so good for osteoarthritis that once they've experienced that, they're very happy to have that again. So chronic tendon pain. Yep.
I have a quick question talking about osteoarthritis. We have a question from Ewan. Asking, do you recommend shockwave therapy after a patient has had an unsuccessful cortisone injection in osteoarthritis specifically?
Totally. Every time. Yes, I would. They recommend you wait for 6 weeks after a cortisone injection before you use shockwave. Mm-hmm. And generally, I think that's because people have an altered sensation as well. Like, you know, so the tissues, their sensation might be a little bit, they're not getting a true indication of what's happening around that joint. But I would say definitely, and that happens quite often because people are frustrated. They've gone through the pain of a cortisone and it didn't work. So, and sometimes depending on who's doing the cortisone, they can be a bit hit and miss. If they're done under a guided ultrasound, they're sometimes better, but sometimes the doctors that are performing them or the specialists just randomly try and hit the spot and they might not get where the pain's coming from.
Okay, thank you.
That's okay. So if we talk about chronic tendon pain or osteoarthritis, another example would be, So the tendon has trouble gliding in its sheath. Now it's become quite thickened. Sometimes we can feel little bumps on the tendon, and sometimes patients will feel the bumps themselves and tell you, what's that lump in my Achilles? They'll ask you these questions. So this increases inflammation and scarring, which further breaks down the tendon. So the more lumps and the more rubbing of that tendon on the sheath, the more it damages the tendon. So chronic tendons do not glide well. And sometimes you can feel through the sheath they don't glide well. So then this is when I talk about lubricin. I say normally there's a glycoprotein that's called lubricin, which is essentially a lubricant. Most people know what that is. That's depleted in chronic tendons and in osteoarthritis. So this lack of lubricant in our joints or our tendons is why they feel dry or like there's sand in the joint. That's often something people can relate to. They say, oh yeah, I know exactly how that feels. This constant rubbing is the reason we feel pain. So that's often how, in simple terms, I will explain how important lubricin is and how the lack of it causes more tendon pain and more osteoarthritis. Why is shockwave appealing to people? It's seen as elitist. So when you tell people that, it's used in the Olympics, it's now part of, every Olympic Games, obviously not this year, but if they're a football fan, you can say things like, did you know all the AFL clubs have them now? Which they never used to. If they're a soccer football fan, did you know France was the only team in the World Cup to use the exact same machine? If they're a golfer, I say things like, I look after players that are worth millions of dollars. I wouldn't use technology that doesn't have research to back it up. And I'm not lying when I say that often. And I do see a lot of golfers. So that's also an easy way, like as soon as they say, oh, well, if someone who's professional has this technology used on them, then I'm more than happy to use it. Find a connection with your patient again. So whatever that may be, find some reason to connect with them. So it could be through a hobby or an interest they have that they might tell you about automatically. It could be they're a collector of old cars and, you might like old cars. So all of a sudden there's a connection. So the connection doesn't have to be over shockwave. The connection is just so they trust you. So that connection with your patient is they find it appealing because they've connected with you and therefore it's already appealing because they trust you and you're telling them it's a good idea. If you see a tradesman, I saw a carpenter last week with the exact same condition. He was back at work the next day. So most tradesmen who are a lot of them are self-employed. So they can't afford to miss work. They can't afford to be out of action. They've got jobs waiting, they've got people waiting, and they're very frustrated that they can't work. So if they're a tradesman, and it doesn't matter what they are, they could be a bricklayer or an electrician. And if you say to them, I saw another one of the same version of what they are last week with the same problem, and they were able to go back to work, that's already like a great positive message that you're sending. There's a good chance they're going to be able to go to work after you treat them. So you're giving them that hope, which is really important. If it's a new mum, so I often say things like, I also had the same problem when I had my children. I understand you can't afford to be out of action as a new mum. So again, it doesn't matter build a connection. It doesn't matter what it is, but make it relate back to what's important to them. Find that emotional connection to the people that you're speaking to. So to make sure people are satisfied with the shockwave treatment you're delivering, listen where is the major symptom. So if it's a plantar fascia patient, sometimes where they're experiencing the pain is not where the problem is coming from. So if your diagnosis isn't correct so if someone comes in and you automatically treat the location of the pain and they come in with plantar fascia and you automatically go, I'm going to treat the plantar fascia without assessing the rest of their body, there's a good chance you're not going to help them. So if you're listening to what they say to you, so I often say to them, the area you have pain may not be where the problem is. Our bodies are very good at compensating. If I shockwave your plantar fascia, but we don't address that hip problem that is causing you to land harder on the ground when you walk, you'll continue to have that plantar fascia pain. So I try and as osteopaths, we generally look at the whole person. So we tend to assess everyone before we go in and shockwave. So it's really important that if people haven't had a good result, or you feel like, I really thought they were going to get better with that treatment, they should have, with my shockwave, I followed the protocol, I did everything I should. If they come back and they're no better, make sure you haven't missed anything else. So listen to where they're major, listen to what they tell you and what's the major symptom. Connect emotionally, show empathy and understanding. So if they're a club golfer, I know you really want to play in the club championships next week. I really believe this will give you the best chance of lasting the entire 18 holes. So again, that emotional connection, you really feel for them. They really want to play golf. Show that empathy, show that you understand, you really care, and you really want them to get better. Be clear and realistic, meet their expectations. So I'm very honest again, always up front, saying generally we see a positive change in the first shockwave session. The recommended protocol for this condition is 3 to 4 sessions. Some people may respond in less, but we'll know today if the treatment is suitable for you. So I don't string them along trying to keep treating them if we don't get a change. I don't find that effective. And I feel like, you know, if their body's not responding, and it could be maybe their tissues are not healthy, that might be another reason, that there's no point. So be clear, be realistic, and they'll appreciate that. Use objective data where possible, like the tennis elbow example I gave you before. So I just wrote it down. So, and I highlight the positive gains. Today's session, we improved your grip strength by 5 kilos. That's great news. Value their time and their money, but do not make financial decisions for them. So your duty of care as a professional is to recommend the necessary treatment protocol. If you go to the dentist and you need a filling done or some treatment, and they say it's going to take 5 treatments for a root canal, you don't say, oh, I'm only going to do 1 because, you know, I can't afford to do the rest. That just doesn't work. The protocol is the entire treatment. It's no different with shockwave. So I think you need to keep in mind, if you honestly think this is the best choice of treatment for the person, then you need to recommend what's recommended as the appropriate protocol. That's your duty of care as a practitioner. So I often say, if people financially, you might feel it's a little bit of a touchy, you know, if you're charging extra for shockwave, you know, you can say, although it's an additional fee, if overall you need less treatment, then you're going to be saving time and money long term. And I think, especially with the current circumstances, money could be an issue for a lot of people because they may have lost their job, or you don't know, like the situation currently has, you know, could possibly have an effect on people. So explain that to them, that if you know, normally this treatment, I would have to see you, you know, 6 or 10 times. Then if we can get it better in 3 times, even though you're paying a little bit extra each treatment, overall, you're going to be saving money. So I think maybe depending on the system you have set up in your practice, make that really clear to them about that potentially you're going to, you are considering their financial situation. And we know the healing effects last for 2 years. So if you have someone who typically says, oh, I need to go to the physio every month for this problem, and I've been doing that for years. Well, if with potentially that Achilles tendon, we've shockwaved it, and we know the effects are lasting for 2 years and more, that's what the research tells us, they might not need more treatment after that. They might be fine. So you might have cured them. Outcomes, really important. Be firm, be confident, be considerate. So discuss them always at the end of the treatment. When you speak to them and you're talking about outcomes, be slow, be deliberate, highlight the outcome. So the fact that we got a positive change today is an excellent sign that your tissues are healthy. That's a tick. So it's important we don't wait too long to capitalize on the benefits we created today. Read book with confidence. So if you leave it too long in between shockwave, you lose some of that benefit, some of that blood flow, all the lubricant. You want to capitalize on that. So I generally wouldn't leave more than a week in between treatments. And quite often I've brought, you know, if I think this person's, you know, I could bring them in maybe on a Monday, then maybe on a Thursday of the same week, and feel like I'm really going to try make the most out of the first physiological changes we made on that tendon. Discuss possible side effects. So I always say to them, the side effects are minimal. You may develop a bruise, some reddening, some numbness, or some slight swelling over the area. make sure you tell them so they're not shocked if they go home and there's a bruise or it looks a bit swollen, because then you've told them they're fine. But if you don't tell them, then they panic. Question time. Did you have any questions about the treatment? If they're still thinking about the idea of shockwave and you think it's a good idea and they're not sure, give them a brochure, give them some information, say, take it home and read it, and then come back and ask me some questions next time. Be prepared before you see them again. So like we said before, it's part of being a good communicator. If there's been no change to their symptoms, so you give them a shockwave session, they come back and they've had no change. The pain is exactly the same. Be prepared, right? This could potentially happen. So you say things like, I'm surprised you didn't respond. There is a small percentage of the population that don't respond and we aren't sure why. And there has been a study done with the DolorClast that shows they used these little worms that were called C. elegans worms, and they basically have a similar nerve structure to us. And so when they used the shockwave on them, the majority of them were paralyzed, but there were a few that weren't paralyzed for some reason. So the inhibition on those their nervous system didn't seem to work, and it seems to be the same in people. But again, explain that to them, but don't feel bad because, you know, most people do respond. If they're worse, again, don't be shocked. So if they come back and they go, oh, I'm actually worse than before you did that, say, you can apologize. Say, I'm sorry you had that reaction. Possibly increasing the blood flow to the area stirred up some inflammation. Our inflammatory cells are always brought in to help with healing. So sometimes inflammation isn't bad because sometimes that's what the body needs. So that's why it creates inflammation, because it needs to help with healing. But if that spikes their pain, then they might feel like you've done something wrong. So if you're prepared and you're not as shocked, then you won't be like, oh, panicking, and you're not caught off guard and sounding awkward. So the 4 steps to the DolorClast checklist: speak clearly and confidently. So I think this is a really important, so if you say things like, I had a gentleman in 5 years ago with terrible osteoarthritis. He was booked in for a knee replacement. I used the power handle. We did 8 sessions and he still hasn't had the knee replacement. That's really confident. That's really clear. That's really almost instilling and empowering, like for a patient to hear. Because who wants a knee replacement? Sorry, I don't know why that came out second, but positive focus. It's great you can go to work tomorrow, whereas if you had the cortisone, you would need to rest for 2 weeks. So cortisone, they will always be told to have a rest after cortisone. Whereas the great thing I love about the DolorClast is if you're a tradesman, you can go to work tomorrow. If you're an athlete, you can play today, tomorrow, you can compete. You don't have to wait. So I love the fact I always find something positive to focus on. It's like number 1 of the checklist, right? Tell the story, connect, create deeper relationships, build that rapport, build the confidence, reinforce the treatment. So as I said, support the area you've treated using tape or a brace or exercises. And I tell them that's what I'm doing. I'm going to tape your Achilles to keep the load off it. This will maximize the benefits from the shockwave treatment. Exercises, also important. They're going to reinforce what we're trying to achieve. So we also know that shockwave and, you know, if we do shockwave alone or shockwave with eccentric exercises, we actually get better results. So I will always support with exercise. Rebook. Do not say, see how you go. If you don't follow up, you won't know if the treatment is successful and you're under-servicing. So sometimes people, if you only do 1 session and you never see them again, how do you even know if you were effective or that the treatment wasn't effective? So it's really important as a practitioner that you see them again, purely so you know if that was a good idea for that sort of condition and for that sort of patient. When you're rebooking, I've given 2 examples here. So one is if they're an athlete or they play any kind of sport, great, that heel pain isn't bothering you anymore when you were training. Let's see you in 2 weeks after you played your first game back. Very confident. Just tell them exactly when you want to see them. Don't leave it up to them to decide. You be firm. Because again, that will dictate the healing and the response with the treatment. So if you leave it too long sometimes, you don't get that opportunity to maximize all the work you've done. A tradesman who owns his own business. Great, the pain has settled. I know it's difficult when you're self-employed. You can't afford to be out of action. So because this is a busy time of year for you, let's not wait for another acute episode. Let's see you in 2 weeks. And if all is going well, we can stretch the treatment out to once a month. So he knows ahead. I'm not just bringing him in every week just for the sake of it. The plan is we'll check on you, make sure you're okay, and then we'll see you in a month and continue doing that, and then gradually spread him out until he's fine and can self-manage. So these are the references for some of the things we discussed today, if you want to have a look at those. And if you're interested in any other courses or webinars, here are the links attached. If you'd like to connect with us here at Coburg Osteo, you can follow us on Instagram or Facebook or on our webpage. We're also on TikTok now. We have a YouTube channel, Coburg Osteopathy and Health Services. If you want any other information from a local representative, Daniel Tan is your best contact, and he will refer you to whoever is the appropriate person in your country. Swiss DolorClast, the Facebook links are there, and also, as I said before, make sure you register on the Swiss DolorClast Academy. We will be running another course on June the 18th, and I will be running an actual practical webinar. So I will be demonstrating how I basically treat certain indications and how I support using tape, and potentially the sorts of things I explain to patients about, depending on the indication, what we say to patients after we treat with shockwave. So hopefully by then we can see some of you again, and we can connect with you, and you can tell us how your communication's going. And hopefully some of the tips and tricks we talked about tonight you can put into practice next time you see a patient and you think you're recommending shockwave for them. I think that would be, hopefully you found some value in this webinar this evening. Thank you so much for listening. Any questions?
Thank you, Tina, for sharing your experience with shockwave therapy. That was very, very interesting. We have lots of questions, lots of enthusiasm around the DolorClast, and we have a list of questions. So I'm just looking at the chat section, and we had a question about how to handle patients who are not keen on having a painful treatment and will bruise quickly. How would you tell them? How would you reassure them?
With their bruise, sorry, if they bruise quickly, was that the question?
Yeah, if they will bruise, if they have bruises quickly.
Yeah. So I don't like, I think the bruise will go away, but I say things like, they can ice if they need to when they go home, if they want to apply some ice to the area to try and relieve some of that. But I'm just reassuring them is the biggest thing, that it's quite that it can be a normal response. But if they're bruising a lot, you might be checking like blood wise. They might need a blood test to see if there's an issue with why they bruise. Potentially there could be something else going on with them.
Okay, thank you. Another question from Farius, can it be used for TMJ degeneration too?
I don't.
Joint, yeah.
Yeah, I haven't seen an indication for TMJ. There's no research that I'm aware of, but I just think just to the proximity to the head, it won't be a very nice sensation. So I'd probably say no. I probably wouldn't use it on a TMJ that's arthritic.
Okay. Another question from Heidi Adams. What about patients who say they are feeling nauseous on certain trigger points? What do you tell them?
Yeah, any particular part of the body, because if you're having an impact on the sympathetic nervous system, potentially that could give them a feeling of nausea. Mm-hmm. So it probably depends on where the trigger points are.
It's true, we have trigger points are all over the body, but it's not.
Yeah, but I think
yeah.
I think when you're impacting a nervous system, the impact is systemic. We're changing things in the brain. So overall, so it could be it could be just, you know, that patient in particular, but I think I wouldn't be, I just reassure them, and hopefully, you know, they don't feel actually sick from it, like too sick to the point where they're actually going to vomit.
Okay. Do you think feeling nauseous would be, let's say, part of the healing process, or is it part of a...
Potentially, if a lot of toxins are moving around your body, that can often make you feel quite sick. So if you've got quite chronic trigger points and chronic tendons and things that have not been moved for a long time, and you're sort of upsetting the apple cart a little bit, I think, you know, sometimes we can expect these systemic sort of responses from the body.
Yeah, okay. Thank you. A question from Chris. What is your treatment regime for Osgood-Schlatter's disease? What about Sever's disease? And he would like to know your thoughts on the use of injectable local anesthetics to markedly reduce the pain of shockwave therapy.
Yeah, the problem I have with, I understand they're quite painful conditions, and we do see quite a lot of them, but I think the really important thing is that if you're using a local anesthetic, then it's very hard to get an indication from the patient of what they're feeling. So it's really, the feedback they give you is basically will determine the path you take. So are you going to put more pressure in? Are you going to increase the hertz or the the actual amplitude of the energy you're providing to that area? If that's numb because of anesthetic, there's no way of you telling if that's enough or not. So I would say no to anesthetic, because it doesn't give us a clear reading of what the patient is experiencing. And that's really crucial to determine how effective the treatment is.
Thank you. A question from Sam. Is it appropriate to use shockwave therapy for tibialis posterior tendinopathy?
Yes, it's fine. And you can use it on any tendon really, like if you can access it. And if you can, it depends on whereabouts on the person, like they're feeling it. But if it's, you know, a lot of the time we've got tib posts behind the ankle where I tend to see people who run a lot develop a chronic tendinopathy through there. So very effective for that.
Okay. Thank you. We have another question from Greg asking, still in the chat section, do you still achieve the same result if you need to pause for a minute or so due to patient discomfort and continue to achieve the 2000 impulses?
Yeah, I think it depends again on what you're treating, on the condition you're treating. So if you stop and you're like repositioning, you might be, so for example, if I was treating, say I'm going to treat around the knee, I might treat along the joint line, I'll treat around the patella. So direct my shock waves all around different directions to try and maximize the overall lubricant produced in that knee. So I come at it from different angles. So in between I am stopping and I still get good results. So I think as long as you don't wait too long, it's fine.
Perfect. We have a question from Himani. Can it be used in patients with rheumatoid arthritis? Do you have any side effects considering the regular medications?
Yeah, so again, I'd probably, they usually are under the care of a rheumatologist, so I'd run it by them. If they're having an acute episode where we have a lot of swelling, a lot of redness, a lot of heat, I wouldn't use it, because you don't want to increase more blood flow to a very acute joint. So if it's chronic arthritis, like an osteoarthritis, it responds better. But I think you could potentially aggravate them if they've already got quite an inflamed rheumatoid arthritic joint. But you can always check with their rheumatologist, would probably be the best advice.
Okay, thank you. I'm still reading the chat. We have a question from Jacqueline. Following TA repair, can shockwave therapy be used, and how long after the repair?
It can sort of, so with scar tissue really, like we're talking about trying to improve blood flow and break down scar tissue. So I think as long as the healing has actually happened and you're on a low setting, with a large head, I think it's great time to try and break down scar tissue. So I'd probably say after they've been given the all clear from their surgeons, then basically then, you know, your rehab can happen from there on in. So you can start to gradually work around the area, around the repair, and work in towards like the scars.
Okay, thank you. We have an interesting question from Nerina, a question that was coming very often in our webinars. So one of the indications in the approved indications of the DolorClast method is chronic cervical pain. What is your approach with this? Because sometimes practitioners are afraid of using it because it's near the spine. How do you approach this? Paraspinally, maybe?
Yeah, I do approach it posteriorly, and I do angle the DolorClast on a 45-degree angle towards the spine. So I'm trying to avoid the vascular structures. So I try and actually feel like I'm over the facet joint, which typically is where they get their pain from when they've got arthritis or degenerative cervicals.
Okay. And do you put the handpiece in a certain angle?
Yes, so I'd put it, I come at the spine sort of on a 45-degree to the spinous process. Yep.
Okay, perfect. Thank you. Other questions now in the Q&A section. Can we treat patients with factor V Leiden, inherited blood clotting disorder, who's not taking any medication for this disorder?
Sorry, I don't actually know what that is. So a clotting disorder. Again, if there's something you're not sure about, you're best to run it by their doctor. And if they've got a clotting disorder that's not medicated, like you need to ask the questions like, why is that the case? Does that make sense? So you are impacting blood flow. Also, what about those who if they take blood thinners daily, they're gonna probably bleed quite a lot. So they don't often respond well because you do cause, you know, quite a lot of bruising. So that often like alarms them. But if it's a joint, I think sometimes the bruising outweighs the benefit of the lubricant that you're creating in that joint. So it depends on what you're treating, because sometimes the blood thinning and the bruising and the bleeding the benefit to the joint might outweigh that. So it really depends on, it's a case by case, I'd say. It's hard to just generally, you know, I don't think there's an answer for everyone, sorry. But if you're in doubt, always check with their doctor.
Okay, thank you, Tina. We have another question saying, do you do any other treatment in conjunction when you treat with shockwave, or do you only use shockwave? So you talked about using taping, but do you use any other treatment, kind of treatment?
Definitely. Yes. So obviously I'm an osteopath, so we do a lot of manual techniques, lots of stretching, muscle energy, manipulation. We do lots of, you know, soft tissue work. So we do a whole host of manual therapy techniques. So shockwave is a tool I use in conjunction with that treatment. I hardly ever see someone, like whenever I see someone, I will assess them. And then I might think that shockwave is a good tool. So that will become part of the treatment. And then if I feel like they need just shockwave again, I might get them to come in just for a shockwave, like a top up. But I do like 9 times out of 10, I do my manual therapy as well as the shockwave. So definitely in conjunction with other techniques. In saying that though, sometimes if they're in too much pain and I can't perform a technique, say I want to manipulate their radial head, but their tennis elbow is so painful that I can't actually do that. So I might use the shockwave to reduce their pain, and then I can do the manipulation that I couldn't do previously. So sometimes I do the shockwave in between, sometimes I'll do it at the beginning, sometimes it's at the end. It just depends on what presents.
Okay, so combination of techniques is optimal to let's say it optimizes the results.
Yes.
Okay, thank you. How many rounds of shockwave per session? So we talked about, is it 1 round to the pathological tissue or more? How many per session should you undertake, and how far apart each session a week? or 2 weeks?
Yeah, so with the session, like how many shock waves I deliver. So in one session, typically I would do 2,000 is around about the normal for most protocols that we follow for the indications. So I think when you're looking at, sometimes it depends again on the area, but say we're talking about an Achilles tendon, I might use 500 shocks with the large 36 millimeter head. And I might actually do that all along the calf. So I might do through soleus and try and release all the tissues around that to take pressure off the Achilles. Then I might switch to the 15 millimeter and deliver 2,000 shocks to the actual part of the tendon that's where I feel the lump or where I feel the thickening or where most of the pain is. And then I'll work around there. So all up, most people I deliver 2,000, and usually the extra 500 will be to release pressure off that tendon. So in saying that, I would do that like typically once a week, I think is effective. If it's someone who's really struggling and you get a really good change, you can bring them back, but leave maybe 2 or 3 days in between. Still get a good response, no problem with that at all. So generally go with the protocols that are recommended for the indications.
Okay, thank you. Another question linked to cavitation, what we discussed at the beginning of your presentation. Are you able to describe cavitation again? How would you explain cavitation to your patients in simple words?
Okay, so basically I draw the graph for them, the graph that I showed you earlier. So I will say to them, this is the shock wave, this is the spike, and then this is the tissue. We're stressing the tissues by putting a shock into your tissues. So that increases already by doing that. We know that the pressure with this machine is so great and happens so quickly that as it starts to come down, it drops negative. So it drops the tissue pressure, it drops below that. So we get a negative change, a negative pressure in your tissues. And this negative pressure creates little bubbles. Every time those little bubbles pop, we get energy and we get blood flow and we get oxygen and all the good stuff into those tendons. So we need that cavitation to happen. So if I don't create the stress initially with the shock, I'm not going to get the cavitation. So that's what I say to them.
Okay, thank you. That's clear. We have a question concerning a situation with a patient. I've had a patient who had one heel spur respond, but the heel spur on the other foot did not respond. Why would this be the case?
Okay, so I think then there's probably a biomechanical problem, maybe further up the chain. So I would be looking at their knees, their hips, their spine, their pelvis. More than likely, if they've had one painful heel, it would have changed their gait. So the way they walk, the way they run. So they would have developed compensations further up. So sometimes they end up overloading the other foot and they develop pain on that side. And you could treat that with shockwave, but the problem's already happened further up the chain. So you need to go back, look up, and find out when they switched over and started compensating and get rid of that, and they'll come good. So they might not even need the shockwave because purely that pain might have developed due to compensation.
Thank you. Another question from Greg. Can you over-treat in one session? Let's say to treat the plantar heel with 2,000 impulses, then the posterior calcaneal area with 2,000 impulses.
I think if you're treating different locations, I think that's fine. So if you were to treat, right under the heel, and then you were treating, posterior, and they're, far enough apart to not really impact each other, I think you're going to have no problem with that. That would be fine. So it's more, I suppose, the time you actually want to spend treating. So always go with the one that's more painful, like palpate both and always treat that one. And after you've palpated that and you've shockwaved that, reassess the other one and see if that shockwave has had an impact on that tissue. You might find the other one responds.
Okay. Thank you. If the DolorClast only travels 5 centimeters deep, would you really get to the joint space on the average person?
So we know that the power handle can travel up to 7 centimeters. So generally I go medial joint line if we're talking about a knee or an ankle, medial, lateral from both aspects. And then I go, as I said, below the kneecap, underneath the kneecap. So I get it from all. So if I go 7, the average person, I've covered most of the joint, and understanding that then with those ripple effect we talked about before, the blood flow from both directions will keep getting into that joint space. So their joint mechanics are they glide a lot better, and they're significantly smoother before and after. So I always get them to put their hand on their knee, and I say flex and extend that knee, see how that feels. Then we shockwave, and then we reassess, see how that feels now. So immediately they get the feedback. You're not making it up. They feel the difference, but you can feel it as well as a practitioner.
Okay. Thank you. We have a question concerning Olympic Games. A person is asking if shockwave, is shockwave therapy illegal to use at Olympic Games, especially in athletics due to stress fractures?
Not that I'm aware of. I don't think it's illegal. Do you know, MC? I didn't think it was.
No, I'm not sure, because the DolorClast has been used in Olympic Games regularly. So, well, I don't know. It was due to stress fractures. I don't know, because they don't.
Yeah, I'm not sure either.
They don't want the public to know that athletes are suffering from stress fractures. Is it? Well, maybe this reason. I don't know.
I'm not sure.
I'm not sure at all.
Sorry.
So let's pass this question, and do you have a bit more time to answer a couple of questions? A question from Sanita. Can you please explain about how to use shockwave for adhesive capsulitis and osteoarthritis? What is the area of application? Do you look for pain location? What are the outcome measures?
Okay, so basically, adhesive capsulitis is I think is great, because anytime you can improve the lubricant inside a capsule that's sort of stuck in that sort of condition, and same with osteoarthritis, anytime you can improve any gliding, it's going to be beneficial. So when I'm treating adhesive capsulitis, I have the patient with their arm up, and I will treat between the scapula and the rib cage. So subscapularis, I sort of direct my shock in through there. I will start with that, and then I'll come through the front of the shoulder and the back of the shoulder. So I will spread the shocks around the capsule from as many directions as possible. But I find through the axilla quite effective.
Okay, thank you.
Yeah.
Would you recommend a heat pack or ice pack post shockwave treatment?
Again, it probably depends on the condition. If it's an area that I think potentially, it depends on what the response is going to be. If it's chronic and it needs more blood flow, I would definitely recommend heat. But if it's something that's maybe like already quite inflamed or irritated, I might say to settle it down. If it's very sensitive superficially, I would say use ice.
Okay, perfect. Thank you. 5 other questions. Alison is saying, I've used on TMJ post-dislocation, very good response. Earplugs, of course. So,
there you go.
Yeah,
Okay.
We talked about TMG previously. Obviously, this is not in the approved list of indications, but well, she had a good response, so that's good.
Yes. Okay.
So another question from Andy: as an osteopath, Tina, do you provide shockwave within your osteo session, or is it separate service, and then you add an extra cost for shockwave therapy?
As an osteopath, yeah. So I do, as I said, we have a treatment for osteo and shockwave together. We have osteo by itself and we have shockwave by itself. So if people can potentially come in just for shockwave, and so they can have it as a separate service. But if you was your first time coming here, I would always have osteo and shockwave together.
A question from Jessica: will shockwave help stimulate or facilitate the stem cells for regenerative treatment? What about the palate-rich plasma treatment, PRP?
Yep, so used ink, will it stimulate? Well, you're going to get more blood flow to the area. So I think, I haven't seen any research on this, but just understanding the extra circulation and extra cavitation that we're creating, and you're stirring up the blood in the area. So I think it could be beneficial, like to use that if they are having that done, for sure.
Okay. Other question, and then we are coming to the end of our listing of questions. Can you please clarify how the change in the reported pain during a shockwave treatment varies your delivery of that treatment and thus your plans for your patients?
Sure. So that's a good question. So basically, I use a pain scale. So again, like I said before, so I would say to them, let me know when if your pain's 10 out of 10 to start with. So then I'd say, let me know when you feel like it gets to about a 7. Once it gets to about a 7, then I'll increase the pressure. So I'll start at 2 bars of pressure typically, because we know that that's where we need to start to get a therapeutic change. And I'll gradually increase it as they tell me. So if I might have someone there, for 1,000 hits, and they actually haven't told me the pain hasn't gone down yet. So not everyone responds the same. So I usually wait for them to tell me it's dropped at least 2 or 3 levels before I change anything. So I'll keep it consistent. I'll talk to them, reassure them, discuss breathing, whatever you can do to distract them, to just get them through. So those things I think are super important. And then once you feel like there's been substance P starting to go, then you're going to step it up, because the more energy you can put into that tissue, the better the results will be. So you do gradually want to work people up to that 4 bars of pressure, but not everyone's up for that. So, it varies basically on their pain threshold. So you need that as your guide.
Okay, thank you. And last question from Neil in Singapore, coming back to osteoarthritis. What would be the patient selection for osteoarthritis?
So basically, it obviously varies, but usually more often than not, these people have had an X-ray, and so we can see the amount of degeneration and the amount of osteoarthritis in a joint. And some people, are told that basically nothing else can be done. They say, oh, you've got arthritis. The doctor said it's just old age. It's just degeneration, like that. We just need to accept it. Whereas I really feel that osteoarthritis is one of the conditions we can really help with, and really improve quality of life for people. So one of the big things for me is range of motion at the joint. So what's available? What do they have? And what can they do? So I always measure their range. I'll use like a clinometer or an app where I can actually measure range of motion. And I will say to them, okay, that knee, we've got, maybe 100 degrees of knee flexion. Let's try the shockwave and then let's reassess. So mobility is a big factor for me. If their mobility is affected and it's affecting their quality of life, then I will try shockwave on them.
Perfect. Thank you very, very much, Tina. We are coming to the end of our webinar. We have no questions so far in the Q&A and chat sections. And so thank you for sharing all of these details about shockwave therapy. We have a very, very nice comments in the chat. Thanks, amazing presentation, Tina, you are great. Thank you all. Thank you. So I share with you the flowers. Thank you all for participating. Thank you, Tina, for accepting to be our shockwave expert of the day. That was a great presentation and a nice perspective, sharing all of this. We were very happy to have you today, and we are looking forward for our next webinar on the practical session on the 18th of June. So stay tuned, everybody. Again, thank you for joining today. Take care, and we'll see you next month on the 18th of June in our next webinar. Thank you again for your commitment, Tina. And
no problem. Thank you so much for having me. Always a pleasure.
Pleasure too, and see you soon online. Thank you.
Excellent.
Take care, everyone.
Thank
Bye-bye.
you, everyone.
Bye-bye.
Bye.